Yep.
All right. All right. Good evening, guys. My name is Eric Mao. I'm one of the IBD faculty over at UC Davis, as Tim nicely put it in the introduction. Welcome to tonight's webinar. Today, I was been tasked with talking to you about management of complex IBD. I sort of tweaked the topic and just sort of make it updates in IBD management. So I have no relevant disclosures. So objectives for tonight's talk, I want to first to learn to characterize disease activity severity with any sort of IBD patient you come across. I think it's a very useful tool in terms of approaching IBD patients. Then we're going to review the data guiding therapy positioning, because there's an ever-growing field of inflammatory bowel disease. There's ever-growing therapeutic options, and we're getting to the point now where we have a lot of therapeutic options, and now we're sort of having to figure out which come first, which comes second after failing the first one. So I'm going to go over some of the data guiding the therapy positioning algorithms, and then we're going to develop an approach to positioning therapy for ulcerative colitis as well as Crohn's disease. So sort of right off the bat, choosing the right therapy for the patient is not the most easy thing, and it actually encompasses a lot of different factors. Some which we'll go over today, some we won't go over as much. But to start out, current disease activity, how bad is the disease at the moment you're seeing the patient? Then we're also going to have to take into account the overall disease severity, how severe the disease has been since diagnosis, and take that into account when deciding which therapy is best for the patient in front of you. And then comes the sort of the data, in terms of medication efficacy, how effective it is in treating patients, getting patients into clinical remission, endoscopic remission, and then safety concern for both providers and patients. What are the side effects, and how well tolerated is the medication. Then come the sort of the data that's sort of driving our decision making, whether it's real world data or clinical trial data. and then patient preferences is a huge part of this in terms of choosing the right therapy for IBD patients. And then finally, the payer preferences, whether we like to admit it or not, influence the final outcome of whether what therapy goes to a patient or patient goes on. And as much as we try to sort of make decisions for that is in the best interest of the patient, the payer preferences play a role as well in the sort of whole process of choosing a therapy for our IBD patients. So we'll start out with a case. This is a patient I saw in clinic, 64-year-old man. He came in with the bloody diarrhea. Colonoscopy, as you see below, shows severe colitis, probably Mayo 3 given the presence of ulcers. Histology confirms ulcerative colitis. He was initially started on Lialda and Rawasa with only partial response. By the time he got to me, he had a calprotectin greater than 3,000. His infectious workup has been negative. He was anemic to hemoglobin 12.5. Baseline was 13 to 14. And when I was seeing him, he was currently having 10 bloody stools a day. So he was just basically miserable. So this concept of disease activity, we're all very well comfortable, well versed in, is sort of seeing the patient in front of you, assessing how severe disease is at the moment. And there are different ways of sort of going about doing this, but in general, there's sort of looking at symptoms, disease activity, and also going by inflammatory burden. And symptoms is more subjective. Inflammatory burden is looking at more objective markers of disease activity. So on the Crohn's side, symptoms, they have these scores that are called PROs, or patient-reported outcomes, of abdominal pain, stool frequency. There's also some other calculator tests that you can all sort of Google and find, look up about the Harvey-Bradshaw Index, Crohn's CDAI, Crohn's Disease Activity Index. These are a little bit more cumbersome when you look at them, but they give us a sense of where they are in terms of if they're mild, moderate, or severely active disease. And in terms of inflammatory burden, we use our usual biochemical markers, CRP, biologic markers, calprotectin, endoscopic disease, Crohn's disease. They commonly use the scoring system as the simple endoscopic score for Crohn's disease, SESCD, and then there's a cross-sectional imaging as well. Ulcerative colitis, on the other hand, symptoms similar to Crohn's disease. They use PROs. These include stool frequency and rectal bleeding, partial Mayo score, which involves just the clinical aspects, symptoms, unlike the full Mayo score, which actually incorporates the objective endoscopic data as well. And then sort of similarly for the Crohn's, inflammatory burden is measured by CRP, calprotectin, and endoscopic disease. In ulcerative colitis, we commonly use the Mayo score. So in terms of different scores, this is another sort of a proposed score by the ACG looking at ulcerative colitis activity index, and gives us a sense of where the combination of the symptoms as well as objective markers, how they sort of decide how severe disease is. In Crohn's disease, alternatively, there was a study done, old study, but still rings true today, looking at the correlation between CDAI, which is one of the symptomatic scoring systems, versus the CDEIS, which is one of the endoscopic scoring systems. So subjective versus objective inflammation during steroid therapy for Crohn's disease. And there was basically a complete lack of correlation between the CDAI and endoscopic inflammation, as you can see on this plot diagram here. And so basically what this is saying that is the symptoms that you could elicit on your history from a Crohn's patient basically doesn't correlate at all with how severe disease endoscopically on endoscopy it is. So you sort of keep this in mind. Obviously, when you're seeing a patient, their symptoms are important to them and they should be important to you, but to keep in the back of your mind that you always want some objective data to back up your assessment of these patients. So that was disease activity. Disease severity, on the other hand, is looking at sort of the risk potential of that patient of having to experience adverse disease-related complications, whether that be surgery, hospitalizations, disability. In Crohn's disease, these risk factors include young age at diagnosis. Young patients tend to have more severe disease courses, longer disease courses. Endoscopic disease assessment is a major marker of sort of poor prognosis for severe disease in both Crohn's and ulcerative colitis, as we'll see, especially deep ulcers. Typically, we associate deep ulcers with Crohn's disease, but you can see them in ulcerative colitis patients as well. And so deep ulcers is a sort of a universal sign of poor prognostic or a severe disease phenotype. It should always alert you to that, these patients should be treated more aggressively. Extensive disease, both Crohn's and ulcerative colitis when there's pancolitis, Crohn's disease when there's either pancolitis or more than 40 centimeters or 30 centimeters of ileum involved. On Crohn's disease, if there's stricturing or penetrating disease, or if there's any history of intestinal destruction or presence of a stoma, they have high-risk disease. Also, if they have perianal disease as well. Extraintestinal manifestations are a bad prognostic sign for both Crohn's and ulcerative colitis. It just means that there's an inflammation in those patients is more systemic or more, it's more systemic. Lab findings on such as a high CRP for both ulcerative colitis and Crohn's disease, low albumin, a presence of anemia also are markers of the more severe disease phenotype. On the ulcerative colitis side, some unique ones are either they have become steroid dependent, which is, you can argue, is a Crohn's disease risk factor as well for severe disease, as well as a CMV or C. diff infection in ulcerative colitis patients. So any sort of presence of any of these disease high risk features should send signals to, when you're assessing and evaluating and deciding what therapy to put these patients on, that even if they're having no symptoms or they're almost asymptomatic, if they have some of these high-risk features, you should be considering putting them on stronger medications, whether that be biologics or small molecules. So boil it down, activity is a cross-sectional assessment of inflammatory impact on symptoms, biomarkers, endoscopy. Severity is a longitudinal assessment with historical factors to provide a complete picture of prognosis and overall disease burden. So in short, activity is how's your patient today. Severity is how has the patient's disease behaved since it was diagnosed. So back to our case, 64-year-old man with left-sided UC, bloody diarrhea despite Lialda mesalamine, disease activity, if you go by the partial Mayo score, is 8, which is correlating with a severe disease activity. And then disease severity, because he has a severe endoscopic disease, Mayo 3 endoscopic subscore, he also is at risk for high-risk disease. So the decision with to start biologic therapy. So in terms of the disease course in Crohn's disease, there's sort of this conception that Crohn's is a progressive disease, and with over time that the progressive inflammation leads to cumulative digestive damage to the bowels. So, when you first are diagnosed, or even before you're diagnosed, there may be some subclinical inflammation, especially in patients without symptoms. But then there's at diagnosis, then that's early disease. That's when you have inflammation come up. That's when symptoms come up, and then that's when diagnosis happens. It depends on how the therapy goes, but the general course is there's ebbing and flowing of inflammation. But every time that they have a flare, they have increased inflammation, that there's cumulative digestive damage, cumulative damage to the intestines. So they eventually start developing strictures, fistula abscess will require surgery, more strictures. And so as you can see over time, untreated, the inflammatory burden or digestive damage burden increases over time. And the thought process is that during this window of opportunity, if you intervene on these high-risk patients with effective therapy, you may be able to lessen the overall inflammatory activity as well as the overall inflammatory burden or digestive damage burden. And originally, they used to think this is only Crohn's disease, but ulcerative colitis, we're starting to see, and we'll probably see on our daily practice, that ulcerative colitis also can be a progressively damaging disease on the intestines. And the sort of example is those patients who have those lead pipe appearing colons where they lost all the normal folds, and so those patients have ulcerative colitis, but their disease has left their colon to be all completely altered, and there's usually when it gets to that point, it doesn't return back to normal. So this accumulative damage to the bowel, initially just thought to be Crohn's, may also be to some degree applied to ulcerative colitis as well. So all the more reason for us to put these patients on effective therapy early on. So how do we choose ulcerative colitis therapy? And we have some practice guidelines from the major societies. The AGA put out one in 2020 on management of moderate to severe ulcerative colitis. ACG put one out in 2019. And so their first recommendation is that adult outpatients with moderate to severe ulcerative colitis, AGA recommends basically anything over nothing, which sort of makes sense, or obviously makes sense. But then how do you choose between different biologics? So there have been some studies looking at positioning first line therapy or positioning of different biologics head to head. And so the first trial was the Varsity trial, which looked at adalimumab versus vedolizumab for ulcerative colitis. And the primary outcome or primary endpoint was overall clinical remission at week 52 at 1 year. And so these patients basically were put in a double-blind, dummy-controlled, randomized controlled trial looking at adalimumab versus vedolizumab. And the primary outcome was that the vedolizumab was superior to adalimumab in achieving clinical remission. That effect was a little bit dulled in the patients with prior anti-TNF exposure. So patients who have already failed or been exposed to prior anti-TNFs, that difference between vedolizumab versus adalimumab was not as apparent. But in anti-TNF naive, we really see that difference. And so, and this held true in terms of the endoscopic response as well, in terms of adalimumab versus vedolizumab. Anti-TNF naive was driving most of that effect compared with anti-TNF failures. Another study that sort of helped guide, treatment of ulcerative colitis is the SERENE UC trial. And this trial was actually looking at, if adalimumab was used, but at a higher dose, would that get us to higher levels of remission? Because the thought process in the community was, IBD community, was that adalimumab was underdosed, and so if you dosed it higher, would you get better results? And you see here that they did the standard dosing induction was 160 at week 0, 80 at week 2, and then 40 at week 4 and week 6. The higher induction dosing was 160 at week 0, 1, 2, 3, and then week 4 they went to the standard dosing. And surprisingly to a lot of people, clinical remission was pretty similar in both the higher induction and standard induction dosing, and there wasn't much in terms of difference in the achievement of clinical remission. So that the higher dose of adalimumab is not playing a role, and so there may be something else, but ulcerative colitis, adalimumab, normal dose, high dose doesn't make that much of a difference. Most of the data driving head-to-head comparisons or positioning of ulcerative colitis therapies is through network meta-analysis done by Sid Singh. And network meta-analysis basically compared data from different clinical trials by using placebo as sort of a common arm, and then sort of extrapolating. So it gives us some sense of how different biologics compare to each other. But again, it's taking into different clinical trials, which may have had slight differences in inclusion criteria and of the patients that were enrolled in each trial. So it's not a exact a substitute to a randomized controlled trial, but it gives us some idea. And they use this measure called the SUCRA, surface under the cumulative ranking, which is the percent of efficacy or safety compared to the imaginary best treatment. So the higher the SUCRA is, the better. So in the comparative efficacy in bio-naive patients who've never been on anti-TNF or any other biologic for that matter, infliximab won out. Infliximab is the best for biologic naive patients. After that, vedolizumab and golimumab for clinical remission, and tofacitinib for endoscopic remission. But infliximab is still the sort of go-to for bio-naive in terms of efficacy. Now, comparing different biologics, if you've been exposed to anti-TNF already, and the study showed that ustekinumab and tofacitinib are more effective and more efficacious than vedolizumab and adalimumab in achieving endoscopic improvement and clinical remission. So these were the findings, as I mentioned before. And in terms of safety, vedolizumab had the lowest risk of infections, followed by ustekinumab in the maintenance trials. Golimumab and tofacitinib were associated with increased risk of the infection. So that gives us a little bit more sort of data to support which one we would give first. But a little bit more on the data driving the ustekinumab and tofacitinib as the second-line therapy, or the favored second-line therapy. So in the Unified trial, which was the registrational trial in ulcerative colitis for ustekinumab, they looked at biologic naive and biologic failure patients after I think after induction at 8 weeks. And basically, if you compare both the bio-naive and bio-failure, the deltas are fairly similar. clinical remission 8.5, 11.5, bio naive bio failure, clinical response 30, 30, and then endoscopic improvement about 12, 14. So this in this subgroup analysis in the unified trial, ustekinumab was fairly equivalent in achieving clinical and endoscopic response, remission, and both bio-naive and bio-experienced patients. So this is sort of guiding that decision. In the tofacitinib pivotal trials, the in Octave 1 and 2, they looked at efficacy outcomes for tofacitinib induction therapy at week 8, comparing placebo versus tofacitinib 10 milligrams BID. And again, if you compare the anti-TNF naive group versus the anti-TNF exposed, the deltas are very similar between clinical remission and mucosal healing. And just as sort of, this was from a DDW earlier this year, they compared patients who had failed, this is a retrospective cohort study, looking at UC patients who had failed a prior anti-TNF and a anti-integrin therapy, most likely vedolizumab. And they either initiated tofacitinib or ustekinumab. And there was no difference in terms of treatment or steroid-free remissions between the two groups. And the steroid-free clinical remission at 12 to 16 weeks was about 40%. The colectomy-free drug survival, so not still being on the medication, was about about 46, 48%. So there's no difference in achieving steroid-free remission in about 40% of patients who failed both anti-TNF and anti-integrin. So again, this maybe suggests that, if you've maybe failed 2 biologics, you could still go to ustekinumab or tofacitinib with some confidence that this a proportion of patients will respond to that therapy. This is another abstract from DDW that basically summarized a lot of the live real world data behind tofacitinib. And the main thing I wanted to highlight here was, there has been a lot of concern about the safety profile of tofacitinib. And in real world data, the serious infections occurred in 4%, abnormal lipids 12%, zoster 3%, thromboembolic events 0.3%. So these are very comparable to the registrational trials. So it's sort of to say that the contrary to the data that I'm going to go into next, the safety data is pretty comparable between the clinical trial setting, which is a very sort of pristine, well curated, closely monitored setting, as opposed to the real world setting. So tofacitinib, as you all may know, the FDA recently reviewed a large randomized safety clinical trial, which the company was required to do. And they found that there is an increased risk of thrombosis, whether that be a PE, DVT, arterial thrombosis, in patients treated with tofacitinib, as well as other JAK inhibitors. But the thing is that this was a cohort of RA patients who were older than 50 years old and had at least one or more cardiovascular risk factor. And so they found that RA patients with one or more cardiovascular risk factor with a higher rate of all-cause mortality, thrombosis with tofacitinib at the 10 milligram BID dosing, but also at the tofacitinib 5 milligram BID dosing versus the anti-TNF. So, but like I mentioned earlier, data from ulcerative colitis patients has not shown an increased risk over baseline. So this will give us some confidence that, as long as you choose the right patient that doesn't have these risk factors, the risks of poorer outcomes such as these complications are less. So to sort of summarize the AGA clinical practice guidelines, in naive to biologic agents, patients with moderate to severe ulcerative colitis should be treated with infliximab or vedolizumab rather than adalimumab for induction and remission. In outpatient moderate to severe ulcerative colitis patients who have previously been exposed to infliximab, particularly patients who had primary non-response, they should be treated with ustekinumab or tofacitinib rather than vedolizumab or adalimumab for induction. One other question that comes up a lot of times with vedolizumab is that if you use vedolizumab first, do you lose some of that first line efficacy of an anti-TNF such as infliximab? And so this is a recent study that they did looking at a retrospective study at patients who were either treated with first-line anti-TNF or second-line anti-TNF. And the first line in those patients were second-line anti-TNF was vedolizumab. And they found efficacy endpoints at 6 months that treatment persistence. So about similar patients remain on the first line or second line anti-TNF at 6 months. Clinical response was similar, and clinical remission also was similar as well. So that being said, I think this gives us some confidence that, in patients who prefer vedolizumab over anti-TNF, that's a reasonable choice, and you don't lose any of that efficacy of the anti-TNF if you use a second line. So conclusions, emerging head-to-head data in the UC, but it's still limited. There's a network meta-analysis that drives the majority of the data on biologic positioning. But keep in mind, network meta-analyses do have their limitations. In my practice, and from my gather from data, vedolizumab is a great first line, superior to adalimumab, remains an option as a second line. But infliximab is also for a great first line. Consider concomitant immunomodulator or proactive TDM for rapid drug clearance patients with high risk for rapid drug clearance. But it remains an option as a second line as well. Ustekinumab and tofacitinib may be better as second line after anti-TNF failure. So back to our case, 64-year-old man with left-sided UC with bloody diarrhea despite Lialda mesalamine. We discussed first-line options, infliximab plus or minus methotrexate, vedolizumab, ustekinumab. He did selected vedolizumab given the priority of safety. But the symptoms remain partially controlled through the course, and after being almost a year on the therapy and escalating the therapy to every 4 weeks into vedolizumab, he had a repeat colonoscopy, which showed persistent Mayo 3 disease. Second-line therapies were offered to the patient, ustekinumab, tofacitinib, or infliximab plus or minus methotrexate, and he ended up choosing infliximab with methotrexate. So that's sort of a whirlwind through positioning therapy for ulcerative colitis. Now we're going to move on to Crohn's disease. And again, there are some guidelines out there that help us make these decisions. There's an AGA as well as ACG, both within the last 2 years. In terms of the Crohn's data, we looked at it, I'm looking at some of the trial data that sort of guides our therapy for these Crohn's patients. And so we looked at GEMINI 3, which is looking at vedolizumab in Crohn's patients, 315 moderate to severe Crohn's patients who had failed anti-TNF, and they randomized them to either one-to-one to either placebo or vedolizumab. And they found that these patients who had failed anti-TNF, failed a prior biologic, they missed the primary endpoint at week 6, but they met it, the same endpoint at week 10. So the left bar graph is week 6, and the right bar graph is week 10. So what I take from this is that it takes vedolizumab a little longer, especially in patients who have prior or have previously failed anti-TNF to reach clinical remission. Similarly, similar message in the Victory Consortium, which was a real-world experience on vedolizumab in Crohn's patients. This was a retrospective cohort study of about 215 patients of moderate to severe Crohn's disease at 7 U.S. academic centers. Overwhelming majority were anti-TNF exposed. And you see that the remission rates, 10% at week 6, 18 at month 6, and 35 at month 12. So there is some benefit to be had in these patients who have failed anti-TNF, but it's a slow process, and sometimes these patients have a hard time waiting that long to get relief. So something to keep in mind. Similarly, in terms of mucosal healing, 6 months, 20%, 12 months, 63%. So that's actually fairly impressive mucosal healing. So vedolizumab can be used as second line, is what I'm get a sense here, but that it takes a little bit longer to achieve those results. This is the Unity trial. So looking at ustekinumab in Crohn's disease, and this is a sort of a sub-analysis looking at patients who had failed anti-TNF, so anti-TNF failures. And we find that, and if you concentrate on the 6 milligram per kilogram dosing, that's what the current dosing that was used for induction. It is effective in getting patients into remission, or a response at least. But the delta is not a delta of about 12. So the ustekinumab is an option second line after anti-TNF failure. If you look at patients who have not failed anti-TNFs, who have not been exposed to anti-TNFs, ustekinumab in those Crohn's patients, there's a bigger delta. And so they combined these two studies and found that overall in this anti-TNF failure as well as anti-TNF naive clinical remission at week 44, it's mostly driven by the patients who were not exposed to anti-TNF or had not failed anti-TNF. That's driving the effect for ustekinumab as second line after anti-TNF failures. Another network meta-analysis looking at what's the best second line Crohn's therapy after anti-TNF failure, and adalimumab and ustekinumab come out ahead. But the most recent study that came out was the SEAVUE study. And this was a multi-center, randomized, blinded, active control study pitting adalimumab versus ustekinumab. And basically, these patients would get either get ustekinumab induction along with placebo injections, or they would get the adalimumab induction and placebo infusion. And from there on, they would get the two medications, either placebo or the active therapy. Placebo injection, but basically they would get a dummy control. So basically they didn't know whether they were getting ustekinumab or adalimumab going forward, and then follow these patients out. And the primary endpoint was clinical remission at 52 weeks. Something to keep in mind about this study was that the majority, or actually all the patients in the SEAVUE study, Crohn's patients, were biologic naive, so they haven't been on any biologics. And then the mean CDAI score was 289, and the range for moderate disease is 220 to 450. So these patients are probably not, at least clinically, not on the more severe disease side. They're probably a little bit less severe. And median duration of disease for these two groups, the adalimumab arm and the ustekinumab arm, was 2.5 years. So this is early disease. And so what they found was that at 52 weeks, clinical remission was virtually equivalent between the adalimumab and the ustekinumab arms. And if you look at a bunch of other clinical secondary endpoints, corticosteroid-free clinical remission, PRO2 symptom remission, clinical remission at week 16, clinical remission through week 52, basically mirrors of each other in terms of efficacy. So there really isn't clinical difference in terms of ustekinumab versus adalimumab in early disease is the takeaway message from this study. They did look at endoscopic remission. They get rates of about 30 to 40% endoscopic remission and endoscopic response rates, which is respectable, and it's sort of helpful to see that, you know, if you start early, you're able to get these patients into endoscopic remission. Safety data at the SEAVUE study, serious infections were essentially equivalent between adalimumab versus ustekinumab. Injection site reactions, surprisingly enough, adalimumab had more injection site reactions, 10% versus 1% in ustekinumab. But for the most part, both very safe therapy options. So we'll look at the AGA clinical practice guidelines for this. And basically this is saying that for moderate to severe Crohn's patients, anti-TNF, vedolizumab, ustekinumab are better than no treatment, which makes sense. But in terms of patients who are naive to biologic drugs, the AGA recommends using infliximab, adalimumab, or ustekinumab over certolizumab for induction, with a strong recommendation. And then they suggest vedolizumab over certolizumab for induction remission with a little bit less strong of a recommendation, conditional recommendation. In adult patients with moderate to severe Crohn's who never responded, so primary non-response to anti-TNF, the AGA recommends ustekinumab, but also gives a conditional recommendation for using vedolizumab over no therapy. In adult patients with moderate to severe Crohn's disease who previously responded to infliximab, so secondary response, AGA recommends that you can try adalimumab or ustekinumab, but also say vedolizumab is an option as well. So again, conclusions: there's minimal head-to-head data. Infliximab or adalimumab is a great first line, but can be used as a second line if secondary loss of response. But if it's secondary loss of response due to immunogenicity, strongly consider concomitant immunomodulator therapy. Ustekinumab is an excellent first line and second line. Vedolizumab may have a delayed onset as a second line, but can be first line for moderate to severe ulcerative or Crohn's disease. Sorry. So to wrap up this talk, the patient perspectives are, as I mentioned earlier, part of the equation in terms of deciding what therapy is best for patients or what makes sense most for the patient. And a lot of times when we counsel patients, we worry that patients seem to be fixated on side effects. But if you look here, only 14%. This is a survey of patients with ulcerative colitis and what their worries were with regards to ulcerative colitis and therapy, and 14% were worried about side effects. More patients, 37% were worried about colon cancer, 30% were worried about having a surgery where they would end up with an ostomy. So I think this gives us some more ammunition, not ammunition maybe, but as much as just sort of a perspective in what patients are actually value and worry about. And so in terms of counseling patients, we can talk about the side effects, but then we should also talk about the alternatives of not going on effective therapy and risking having to develop colon cancer or having to have a surgery where they end up with an ostomy. This is another study that looked at patient perspectives in terms of what kind of risk they would tolerate. And when they dug down deep, they found that they're tolerant for the final health state of medicine with remission, as well as that they would tolerate a risk of greater than 5% of lymphoma, which is way higher than the quoted risk of lymphoma with any sort of anti-TNF, which is like 9 in 10,000. So this just shows that the way we frame risk is important, and in order to be in remission and to avoid ostomies, the patients are willing to take certain risks on. So I think it's important how we convey risk to patients. So in conclusion, I think we were able to go over most of my objectives today. We've learned to characterize disease activity, severity, review the data, guiding therapy positioning, develop an approach to positioning therapy for moderate to severe UC and Crohn's disease. Key takeaway points. Disease activity and severity should guide therapy selection. There's not one correct order of treatments for ulcerative colitis and Crohn's disease. These guidelines give us a sort of a outline, but in the end, think back to that first slide of all the different factors that play into deciding on the right therapy for patients, and the equation is not that simple. So so pay attention to patient preferences and personalize the approach to the therapy of these IBD patients. And with that, thank you, and take any questions.
Thanks, Dr. Mao, for that great talk. I had a few questions, actually. Let's say you have a patient that has sort of moderate severe UC, and you end up starting them on like anti-TNF therapy, and you follow up in terms of getting drug levels and antibody levels. And the patient is, for all intents and purposes, in clinical and endoscopic remission, but the patient doesn't have detectable drug levels or antibody levels. At that point, would you consider continuing therapy, or would you consider switching therapy?
So there's ulcerative colitis patients, moderate to severe, on anti-TNF, in remission, but then you check your drug levels, presumably for proactive monitoring, and you find that the levels are undetectable.
Right.
So that's a not uncommon, or it does happen. And in those patients, you sort of wonder if their disease, and maybe initially was very severe. They started on therapy, they healed, and then possibly the inflammatory process burned out, or it could just be that their immune disease has slowed down or quiescence. And so in those patients, I take into account their whole disease course. If they've been very difficult disease to treat, and this was sort of they got into remission, I would consider increasing the dosage of the infliximab. But the other option is, I would also talk to the patient and ask them, if this is a patient who, we recently got into remission, we check the level and it's undetectable, I would probably check it again, make sure it's a correct lab value. But if it's confirmed and they recently achieved remission, I would consider increasing dosage of it as opposed to switching medications. Now, if this is a patient who's been on infliximab forever, and then you decided to just check a drug level, and it turned out that it's undetectable drug level, you can talk to the patient and say, this, and if they have antibodies, then I would say this drug is not doing anything for you. We're just gonna stop this medication. It's a little tricky when there's no detectable drug and no detectable antibody, but in that case, you could also make the argument that you could de-escalate therapy at that point, especially if they've been in remission for a long time. So it's a conversation to have. It's, in terms of my practice, I don't do, I do more proactive drug monitoring upfront. And then once they're in a steady pattern, then, I might check it once when they're in maintenance therapy. But yeah, it's a tricky situation where if you want to switch after having been in remission for such a long time, yeah, but you said that you sort of have to believe that the data that you've acquired, and if there isn't any undetectable drug level, then it's not really helping. At least near the end, you want to check. Yeah, but you want to confirm it and make sure it's a real lab test, a lab result.
Sure. Yeah, that makes sense. Kind of on a related note to that, I think Robert was asking, are you routinely using drug levels to optimize management of biologics, as in treating to target levels versus just monitoring clinical symptoms?
Yeah, that's a great question. I think, the pendulum is always swinging back and forth in terms of TDM. I think it's now again swinging towards more TDM. But in my practice, in patients who are on anti-TNF, I absolutely do TDM, especially in patients who are not on concomitant immunomodulator therapy. In general, when I start an anti-TNF therapy, I typically try to convince my patient to go on a immunomodulator to prevent immunogenicity, especially if they've had prior immunogenicity or secondary loss of response. But even in first starts of anti-TNF, I try to convince them to go on an immunomodulator, whether that be methotrexate or azathioprine or mercaptopurine, for at least a year to prevent antibody formation. And then after that, I drop the immunomodulator. But in those cases, I'll probably check a level of the anti-TNF at week 14. And recently they came out with a sort of a consensus statement on different drug levels for anti-TNF during early on, whether at week 2, week 6, and at week 14. But so in patients who are immunomodulators, I feel they're a little bit more protected from immunogenicity and lower drug levels, so I can wait till week 14. In patients who have or on anti-TNF monotherapy, patients who either refuse to go on immunomodulators, or if they can't go on it, say they're childbearing age and they don't want to go on they don't want to go on thiopurine, and they can't go on methotrexate. I have those patients more aggressive early TDM. So depending on how severe the disease is, if they're, were induced in the hospital or just left the hospital, I might even check a week 2 level. But typically, I'll probably wait in these patients, check a week 6 level, and then week 6 onward, I'll check another one at week 14 to make sure that things haven't changed. And then from there on, once you're keyed into a good therapeutic level, then you can sort of back off.
Got it. Yeah. And then another question is, what is the latest with respect to kind of this whole concept of the gut microbiome and modulating that when it comes to IBD management?
Yeah, that is a very hot topic. They were doing clinical trials for stool transplants for a while in ulcerative colitis patients and Crohn's patients, and they found that it was more effective in moderate ulcerative colitis patients in inducing remission. But I think with the recent FDA sort of restrictions on the use of fecal transplant, that those trials have sort of been put on hold. But they're moving towards sort of an oral capsule of a FMT it's designed for CDF, but it's also being studied in ulcerative colitis. And so I think that's what we're going to be seeing more. It's hard to say. I think it's more fitting for patients who have moderate ulcerative colitis rather than severe. But yeah, I think that's part of the new wave of medications, or the new trend in the field. So yeah, keep your eyes peeled.
Yeah, I definitely feel like people are looking at the gut microbiome for treating almost every GI disease at this point. So kind of some of the evidence that you presented on UC specifically, it seems that at least for kind of first line therapy, like adalimumab sort of falls out of favor.
Yeah, no, I rarely use adalimumab for first line therapy for ulcerative colitis patients at this point right now. There are certain patients who it can be applicable for, and this is, but in general, I tend to sort of steer them either to vedolizumab first line or ustekinumab first line, actually. So a lot of times, in terms of patients who I can avoid doing immunomodulator therapy, sometimes I'll push them towards the ustekinumab first line. But yeah, adalimumab really has sort of fallen out of favor. I mean, it always has for a long time. I think that adalimumab is just is usually the biologic that's first on the list for a lot of payers. So they say that adalimumab is usually the first line but from the payer's perspective, but from our perspective, we don't have as great of an opinion of adalimumab as first line. So yeah, I think most of my colleagues, I think that when push comes to shove, if they have to be on a biologic or not have to be on a biologic, and adalimumab is that biologic, I probably would still use adalimumab. It's better, and according to the guidelines, it's better than not using anything biologic for therapy. So sometimes, fighting with the insurance companies can be fruitful, but it's not always the case. And sometimes putting them on a biologic and getting them on therapy it's better than sort of delaying therapy for these patients.
Sure. Yeah. One other question was, how often do you use biosimilars in your practice?
Fairly frequently. I think at the current moment, the only biosimilars are the infliximab biosimilars, Inflectra, Avsola, and Renflexis. And I think at UC wide, but at least at UC Davis, first starts now default to Renflexis, infliximab, as opposed to Remicade. So, and we haven't had any issues, and we're seeing more and more payers requesting or mandating that patients who are on Remicade be on non-hospital-based centers also switch from Remicade to either Inflectra or Renflexis. So biosimilars, I think that initially there was a lot of hesitancy, but at this point, I think no one really has any qualms about biosimilars. I don't have any qualms about biosimilars. Patients, I mean, sometimes, it's the way you phrase it to the patients, because from the insurance company, it's all about cost savings. But when you're, but all they do is they send a letter to the patient, and the onus is on you as a provider and your team to sort of talk to the patient and say, this is what's going on with the insurance, why they're doing it. Here's the data for why this is makes sense. So it has created a lot more work for our support staff and us for that matter. But in the spirit of cost savings for healthcare in general, I think it is worthwhile. It's just that the way it is implemented needs to be nuanced.
All right, I think those are all the questions that we have. Dr. Mal, thank you again for an excellent talk. And thank you everyone for attending, and we will see you next month.
Thank you.